All right, welcome everybody. Thanks for joining us. I'm happy to be joined by my friend and colleague, Dr. Demetry Assimakopoulos, today for the final webinar of kind of season one of webinars on my platform. But as I was saying, happy to be joined by my friend and colleague, Dr. Demetry Assimakopoulos, someone I've done lots of work with over the years and whom many of you are familiar with. And we thought it would be cool to do our last session before the summer break about chronic pain. And so today we're going to go through 7 simple ways to enhance outcomes for your chronic pain patients. So the way we're going to do this is we're going to give a little bit of perspective on why we're here. Dimitri's going to introduce himself a little bit, and then we're going to go through those areas, and then hopefully leave some time for Q&A at the end. And if that Q&A goes beyond the hour allotted for the webinar, that's totally fine. I don't have to run off anywhere, and I don't think Demetri does either. So if you don't mind, you can plug your questions into the chat or save them for the end. We can go cameras on and have a discussion about anything we cover today. So that's how we'll go through today. And I've been lecturing about chronic pain for a long time, and Dimitri's, of course, I think the world's leading expert in our profession about chronic pain from a clinical perspective. And we know that that's why most patients sort of come to see us, or any manual therapist for that matter, be it physio or osteo or chiro, is some sort of pain. So I think it's always important for us to understand not only pain science and what we understand about how pain actually happens and the different types of pain, and we'll get to that, but also, the clinical evidence around it. And we thought we'd sort of lean on primarily Dimitri's clinical wisdom here today. So, Dee, why don't you introduce yourself for a minute for those that aren't familiar, and then we'll get into it.
So for those of you who I have met, it's a pleasure to be here with you again. And for those of you who I haven't, it's a pleasure to meet you. My name is Dr. Demetry Assimakopoulos. I'm a chiropractor. I graduated from CMCC in 2012. After that, I started working at the Toronto Western Hospital as a clinical practice leader in their then titled Comprehensive Pain Program. It then moved to Toronto Rehab, which is the same kind of hospital conglomerate of University Health Network. And I worked for almost 10 years with that group as an expert and clinician with the chronic pain team there. I established the very, very first chiropractic clinic in that hospital, and we had residents rotating through there from CMCC all the time. And I was also involved in training physiatry and pain medicine residents as well. I then took a turn in 2023 and went full-time at the Pain and Wellness Center at our community chronic pain program here in Vaughan. So my special interest is entirely in chronic pain management in an interdisciplinary setting with physicians, mindfulness teachers, psychologists, massage therapists, naturopaths. And it truly is an integrated and special place. We do have funding from the provincial government to put on a whole chronic pain program on a one-to-one basis for people who fulfill our decision criteria. So this is what I do, bread and butter, all day, every day.
All right. Well, thanks for that intro. I think, as a friend and colleague, I've watched your career over time, and you've developed kind of a collection of experiences that not many people would have in terms of not only the clinical settings you've been involved in that specifically deal with chronic pain only, but also the degree and complexity of cases you see. And what I've always appreciated about your content and how you put your thought process together from a continuing education perspective is your ability to bring it to like average clinical practice. And I mean that in the nicest way. Like there are lots of concepts from very complex cases that you can draw down into day-to-day chiropractic practice. Because as we know, pain is a pretty complex thing. And I think, even since I graduated before Dimitri by a few years, but I say this a lot when I'm speaking on this topic. The way we're taught about chronic pain now is kind of night and day different than we were taught about it 20 years ago or 21 years ago when I graduated. And just to put that in reference, some of you on the call are probably more experienced than I am, and we used to be taught that someone in chronic pain was probably faking it for some sort of secondary gain, and we went into this kind of algorithm of trying to catch them in a lie with non-organic pain tests and that sort of thing. And I think our evolution in the chronic pain space is a real testament to integrating science and developing our understanding and also putting the patients first in how we do everything in clinical practice. So our goal with this session today was to go into 7 general, but I would also say kind of specific areas, and hope that those on the call today and watching the recording after will start or continue to leverage these things in your clinical practice. So what the way we think of it is putting evidence and clinical experience together into things that you can apply on Monday morning. So without further ado, let's get into the list. The first one we came up with was integrating manual therapy with other treatments. So, Demetri, I'll pass that off to you.
Yeah, for sure. I mean, this is bread and butter. The way I think about it is pendulums swing. And for a long, long time, we were really sold on doing manual therapy only and nothing else, and blaming everything on a strictly a biomedical model, and not being conscious or even thinking about any of the other psychosocial factors, despite the fact that we understood at the time that every phenomenon or every experience that a person has is biopsychosocial. And then the pendulum swung, I think, the other way for many people, and went to only paying attention to psychosocial variables and really kind of being scared of or not wanting to do manual therapy because it became taboo. And I think now what we're doing is we're arriving somewhere in the middle where we can do multiple things, because even manual therapy works on the whole suite of, like, across the biopsychosocial spectrum. So and I remember I swung with that pendulum too, and now I'm kind of arriving in the middle and saying that manual therapy is a good thing. People come to us because they expect manual therapy. So part of that is developing a therapeutic alliance, and part of that is understanding, well, what is the person looking for? And if the person is looking for a solution that involves manual therapy, then laying your hands on them is probably not a good way to start that. Or sorry, not laying hands on them is probably a good way to stop yourself from developing that therapeutic alliance. Because chiropractors, I mean, it's in the name, right? The other way that I think about it is that whether what the person is suffering from is an acute or chronic problem, doing manual therapy like spinal manipulation and mobilization, or we can talk about soft tissue therapy as well, those are frontline guideline-based tools. Where I think chiropractors and all manual therapists, for that matter, fall short is when a person has chronic pain, that person needs manual therapy, but then we have to think about, well, what else is going on that my therapeutic alliance and um, my therapeutic environment can facilitate for that person. So it's really just about taking our base of manual therapy and saying, this is awesome. How do we maximize the effect that we can create by using some other variables or other treatments?
And what I also think is interesting about that is you mentioned touch, which I think is something that's becoming almost unique to chiropractic these days and some other professions too. But I guess the counterpoint there is that it's becoming non-standard in medicine. And if you compare a medical doctor from 150 years ago that would show up with a stethoscope in their hands, there would be that therapeutic alliance developed via touch and examination and trust building and all those things. And I think that's one of the more important things we can leverage as a profession going forward. And the manual therapy itself, there are effects of manual therapy. We're still figuring that out. I've done courses on that. There's a whole bunch of literature there. Interesting stuff. But what I like about how you framed it, Dee, is, it encapsulates all kinds of different aspects of the clinical encounter because you're meeting patient expectations. Because if you go up to someone on the street and say, what does a chiropractor do? They're going to have some understanding that you're going to manipulate them with your hands and put them in positions and put forces through their body. So if you don't do that, you're missing their expectation. Tied into that are all the contextual effects of a positive clinical encounter, nice decor, therapeutic relationship, someone who understands them, will listen to them, will help them identify to the best of our ability a source of their pain and work with them to find a solution, is really sort of puts the whole picture together. The other thing you touched on is that for chiropractors, sometimes we miss the mark of going beyond manual therapy only. And I think chronic pain as a broad condition really dictates that we do that. So that's some of the other things that we're going to touch on as we go through today. And I think, where do you think the pendulum is now, Dee, in terms of because like you said, a few years ago, once all the biopsychosocial stuff started coming out, there was a real kind of movement against manual therapy that you're addicting your patients to passive care, and that's never a good thing to do. And I always just thought that was kind of garbage. And I remember you and I having this talk, and I was trying to bring you back. Like, it's
Yep.
okay to use manual therapy as long as you do it in the right way. So, where do you think we stand on that now?
Well, again, I have to credit you for always being such a great mentor to me. Ever since I was a second year CMCC student,
The
I've
full-time job.
yeah, I've been benefiting from this friendship. So, I think that we're starting to see the pendulum swing back towards the middle. Where it'll go after that, I really have no idea. And in my own personal work, I see a lot of chiropractors coming up to me and saying, what I'm doing isn't working. It usually helps with other people, or it's only working so much. Where do I go from here? So I think that in our profession, there are a lot of chiropractors saying, well, how do I use this amazing tool, but what else do I think about? And if we look at academic institutions like CMCC, they're talking a little bit more about lifestyle. They're talking a little bit more about what pain is. If you look at, I've been heavily involved in the develop or with the people over at the University of Pittsburgh developing their program. They're really starting to take a very holistic stance towards spine care and things like that. So I don't think we'll lose manual therapy again. Where I think things will go in the future is understanding the narrative of what manual therapy does a little bit better. So
Yeah.
speaking to what you said, Sean, we understand that when we put our hands on someone, whether we're doing a manipulation or not, we're eliciting a significant number of responses through countless numbers of mechanisms, both ascending and descending and reflexive, local and systemic. So I think understanding that narrative a bit better is where we're probably going to go. The other thing that I think will evolve is the narrative that the clinician delivers to the person. So, and as we know, throughout our journey of chiropractic, narratives have shifted over time. And I think that as the future goes forward, we're going to start to understand how we educate patients on what we do with our hands as being a holistic thing that causes numerous neurobiological and immunological reactions, but nested in this complex understanding of the biopsychosocial framework and how all of the different variables within the biopsychosocial framework are completely enmeshed. You can't separate them. So when I deliver a spinal manipulation to someone, I'm impacting all of those things simultaneously. I know Peter Stillwell right now, who was involved in our biopsychosocial course that we did with your organization, Sean. He's working on how to actually systematize this.
Hmm.
So when we talk about making sense of pain, when we talk about delivery of pain-based care, what do we do? What does that look like from bookend to bookend? So I see a lot of amazing things happening, and I see chiropractors being heavily involved in that in the future.
Yeah, and I think that the pendulum swing will always hopefully land us in the middle, and that's normally where the truth is for most of these things. So that's good, a good take on it. I like that. So let's move on. Number two, this is something that you specialize in. You created a 10-hour course for my platform on this about phenotyping chronic pain. And I think that's something that, certainly wasn't at least explicitly discussed with my generation of doctor in any discipline, as far as I know. And I think this concept is still relatively new to a lot of people. So, why don't I put up the phenotypes you covered in All Aboard the Pain Train that some of you on the call have probably taken already, but I'll pass that to you, Dee, to go through the importance of this and why it matters.
So this is something that I'm really passionate about. And going through my journey and understanding what pain is, and it was really it was really from the framework of I don't understand this very well. And when I see a person in front of me, when I see the avatar of that person sitting in front of me, what am I looking at? And if I don't know what I'm looking at, and if I don't understand why that person is feeling the way they are, it made me feel really hopeless, just genuinely hopeless. I'm trying everything and it's not working. So that made me think, well, what am I missing here? I don't want to feel hopeless again. And that's why I decided to work with you, Sean, to create this course, All Aboard the Pain Train. The one thing that we talk about in our clinic here at the Pain and Wellness Center when we're doing assessments with our physicians alongside our physicians, but also at the hospital was we don't treat pain unless we know where that pain is coming from. And so I know that I'm kind of bringing that down to a tissue level, but everything is neurobiological, everything is psychological, and everything is social. So I'm not excluding any of the others. But if we're creating a treatment and we're establishing a prognosis, we got to think about holistically what's going on with that person. So in a nutshell, I'm going to describe these various phenotypes as I've described them. So nociceptive pain is defined as pain that is coming from a somatic structure that is not a nerve. So this is pain that's emanating from your joints, your cartilage, your discs, your tendons, your ligaments, fascia, whatever you want to call it, right? And this is the most common thing you're going to see. What I'm talking about as high threshold sensory stimuli is this. We have different kinds of stimuli that our nervous system responds to. So if I'm just caressing my skin here, I am experiencing myself touch my forearm. That is a high threshold stimulus, sorry, a low threshold stimulus. I don't need a lot of stimulation to elicit activity in the receptors that are responding to this that are then going to my brain, right? A high threshold stimulus is if I were to just compress the muscle in the web space of my big hand until it hurts, ow, well, I've had to compress so hard to the point where I elicit activity in specific receptors that are associated with a pain response. And those receptors are called nociceptors. The encoding of that information from receptors is called nociception. And nociceptors are everywhere. And when we elicit nociception, or when we cause nociception to occur, or if it's a high threshold form of stimulation eliciting nociception, that is associated with a pain response. But we can get into the minutia of what all that means. But classically, the understanding of nociceptive dominant pain is that it's pain that's coming from the body, but it's not coming from nerves, right? Inflammatory dominant pain means that there is some kind of an inflammatory response that is lowering the threshold to elicit activity in our peripheral nociceptors that are in tissue. So you can imagine how somebody might have a little bit of shoulder pain from a chronic rotator cuff tear. They do something, they might have more of a tear, or maybe they incited an inflammatory response in the bursa, something like that. And then suddenly now they have significant amounts of pain all the time. And the things that are typically not so painful are really painful. So all we did was we reduced the threshold of firing of nociceptors there. Peripheral neuropathic pain is exactly what that means. That is pain that comes from damage, or alternatively, a lesion or a disease of the nervous system, of the peripheral nervous system. And we deliberately in this course talk about peripheral neuropathic pain because the way it looks when it's from the brain and spinal cord, brainstem, cerebellum, can look completely different from lesions in the or diseases affecting the peripheral nervous system. So you can think about things like the leg pain that's associated with radiculopathy from the lumbar spine, or arm pain from the same disease. You can think about diabetic peripheral neuropathy. You can think about a whole host of multiple different clinical syndromes that might present. Now, I'm going to stop here for a second because sometimes Because nociceptive and inflammatory dominant pains are the most common ones to come into our office, we kind of get stuck there. And if we have the tools to be able to understand, no, wait, this is more neuropathic dominant, it might change your prognosis, it might change the treatment strategy, it might change how you educate your patient, it might make you render a referral to another clinician. It can completely change how you treat. So that's why distinguishing these things is very important. Now, nociplastic dominant pain is pain that is coming from changes in how the central nervous system is functioning. So you can think about your quintessential example of this in fibromyalgia, or irritable bowel is another one, whereby you can look for a nociceptive lesion. Where's the tissue damage? Or you can look for a neuropathic pain. Where's the lesion in the nerve, or the disease in the nerve? And you might find a little something, but it doesn't explain the entire clinical presentation. Now, if you exclude those two and you have people who are diffusely tender kind of everywhere, their pain is not located in a well circumscribed region, it's kind of diffuse. So if a patient comes in and says, "Oh, doc, I have pain in this region," well, that's not necessarily nociplastic. Pain from nociplastic pain is here, all the way across, all the way down to the middle back. Or they might have pain in the entire back and the head. They might also have different sensitivities, like sensitivity to light, sensitivity to sound, smell. They might have other clinical syndromes. So the person has non-specific low back pain or non-specific neck pain. They might have irritable bowel. They might have irritable bladder. They might have migraines. They might have numerous conditions that kind of come together. So if you see a person like that, start to have your spidey sense about there's a bit more going on here. So the mnemonic that's really, really good for people to remember is SPACE, SPACE. People with nociplastic dominant pain have difficulty sleeping. That's the S. They might have widespread pain. That's the P. And remember, I mean more widespread. It's more diffuse. It's not just a couple of trigger points. It's diffuse in a larger area. A is affect. They have some kind of affective or change in their emotional state, but that's not dominating the clinical picture. So they might have some depression, some anxiety, but it doesn't, or some catastrophization, but it's not defining the entire clinical picture. C is issues with concentration, which again comes with sleep issues and affective, right? So they might say, oh, you know what, it's really hard for me to follow reading. It's hard for me to follow people when they're speaking to me. I'm having difficulty with recall, things like that. And then E is energy deficit. So space, sleep, widespread pain or diffuse pain, affect, concentration, and energy deficit. So once you see those things, your spidey sense should start tingling about a nociplastic dominant pain presentation. And the psycho-emotional dominant pain is a dominant pain phenotype isn't a mechanism for pain. So there are three mechanisms. There's nociceptive pain, there's neuropathic pain, and then there's nociplastic pain. Those are the three types of mechanisms that we know of right now. Someone's emotional state is not a mechanism for pain. It probably impacts the other three. So what I'm talking about when I say psycho-emotional dominant pain phenotype is that the emotional state, the affect, is their catastrophization, their perception of injustice, their kinesiophobia. Those are the things that are dominating their behavior and the clinical picture. So these are the people who maybe you want to give them a forward bending stretch, but they're way too petrified to even think about bending over, never mind bending over. Or these are the people who say, you know what, I think you should start lifting a little bit in order to recondition your body. No, I can't lift. It's going to throw my back out. Or the person feels very hopeless about their pain. These are the people you're peeling off the floor because they're so depressed they can't get out of bed, never mind go for a walk. Or the person you're peeling from the ceiling because they're too anxious. They can't, and it's overwhelming them. They can't not worry about something. So it affects their ability to be involved in some kind of care. So it's more about behavior when we're talking about the psycho-emotional dominant as opposed to a mechanism. And any one of these might change how you treat that person. So that's why it's important to consider them.
Okay, that's whenever I hear you go through those, I'm always really upset that we weren't taught that way in the first place, because it helps you. As Demetri was explaining those, I'm sure everyone listening has patients in their mind in their own practice that slot into those. And I always think it's worth mentioning that patients are allowed to have more than one phenotype, right? I mean, and the psycho-emotional dominant, as you said, can just kind of be layered on top of everything else. And we're going to get to a couple of things that touch on that in a moment. So, for those of you that are interested in a deeper dive here about this topic, Demetri put together, I asked him to do an 8 hour program for me a few years ago, and it ended up being 10 because there's so much stuff to cover here. So, all aboard the Pain Train, a chiropractor's guide to chronic pains, a 10-hour e-seminar available on my platform that goes deep dive into all of those different phenotypes with clinical tools and tricks and treatment strategies for each one. And for those of you on the webinar today, I'll send you guys a 30% off coupon in the follow-up email with the recording for this. If you guys haven't checked out that course, I know specifically some of you who are signed up for this have taken this course already. But it's just a really, to me, it's kind of core curriculum for most practicing, if not all practicing chiropractors. And I have a question about phenotyping, D, but I want to move on. And if we have time for it, I'll bring it back to you at the end. But in a manner of figuring out what type of phenotype we have, our next tip to improve outcomes is to use a body pain diagram. And I think that's something that not all chiropractors do. So why do you think that's important in clinical practice for our colleagues?
From my perspective, if there was any one tool, any one questionnaire that I would use, it would be the body pain diagram because it gives you so much information. Most of the time, we use it just to understand where the pain is localized to, so that way we can kind of get our heads in check. Or we say, oh, this person is highlighting everything, they've circled everything, they've written outside the line, so they're malingering, right? And that's the
Yeah,
way
lightning bolts they draw on the
I've seen
outside. Yeah,
that. But we can use it for so much more. So if we consider the phenotypes, if someone has well localized pain right here, that's not in the periphery into an arm or not in the periphery into a leg, we might think, oh, that's more nociceptive, or that might be inflammatory depending on the timeline, right? If the person comes in, they say, oh, I got this low back pain, but it's going into my leg, that might trigger you to say, oh, I wonder if this is more neuropathic. I might put my mind into asking more questions about whether or not it is neuropathic. That might trigger me to do a neurological exam and what have you. If someone shades more than 20% of the surface area on a pain diagram, keeping in mind that one palm is about 1%, you might start to say, I wonder if there's a little bit more going on from a psycho-emotional perspective or from a generalized pain sensitivity perspective. And some of this research that's been done just on the pain diagram is fascinating. One thing that has been shown is that people who shade more than 20% on the diagram have more psychosocial stressor load. They utilize more healthcare. They visit the healthcare providers more often and have more healthcare providers. So they might get jumbled messages. They have a greater propensity towards describing neuropathic pain. But as we know, the greater the surface area, the more likely there is to be a more nociplastic, right? So we're relating that back to phenotype. So this is a key indicator of pointing you in the right direction. So this person has more widespread pain. I might ask more questions about nociplastic. Oh, it's more well circumscribed. I'm not really concerned about this. Oh, it's going down their arm. I might ask more questions about neuropathic pain. But the one thing that's interesting is that the more area they shade in, but also the more intricate that person is with how they shade it in, if they're really detailed about it, if they're shading in specific areas more than other areas, I'm automatically going to start asking more questions about their mood and about their suffering with pain, and also about the context of their life. Um, and more recent research from out of the University of Denmark, their chiropractic school, has actually shown that people with neck and or mid back pain and people with low back pain, the more area they shade and the more intricate they are with shading, the greater likelihood there is to be some kind of comorbid mood issue happening. So you as a clinician, that should get your spidey sense tingling.
And I think that goes well beyond what most people would think of on a pain diagram, because what I'm hearing there is you get lots of useful clinical information, but it also helps you with phenotyping and also helps you with, I always think of this broad question when I deal with a new patient is what kind of person am I dealing with here? And is this someone that if you think of, I guess what I'm trying to get at long term is what are chiropractors missing in practice about this whole concept? Because I think sometimes chiropractors are kind of point and shoot by nature. Like you have pain here, I'm going to treat here, see if that helps. But I think what you're getting at is that there are all kinds of indicators you can get from these simple tools to point you to the notion that this is a more complex case that's going to need a little bit more in terms of treatment. And I don't say that to exclude chiropractic as a good treatment option. I just think that should encourage clinicians to be a little bit more detailed.
And not only to be detailed, but also to think about like how am I going to allocate my time, right?
Hmm.
So I always relate it back to developing a good therapeutic relationship. So there are many people who you might come in with neck pain, you adjust them, you do some soft tissue therapy. In that 15-20 minute visit, that person's gone. You really don't need to devote much time and energy to it, right? But then there are the people that come in and you have to spend more energy and or more time doing more with your hands, but you also have to sit there and think about what's going on in this person's life. Are they going through anything right now? Can you be a sounding board for them or even just listen to them because you're the only person that they listen or that listens to them in their life perhaps. And there are certain people you kind of get an intuitive sense of who you need to do that with and who you don't. And the body pain diagram might give you a little bit of insight into who you might want to do that with and who you don't necessarily have to. So it's all about allocating time and resources in my mind.
Yeah, and I think that's part of the beauty of chiropractic practice is that we have time to ascertain what sort of relationship this person might benefit more from because we have time with them. And I think that's something a lot of healthcare providers don't have in order to generate a good therapeutic relationship and have the adaptability to change what they do over time based on what might change in a patient's life. So I really like the body pain diagram as a good way to help you start understanding what kind of person you're dealing with. And I think the Danish work is really interesting that the intricacy of how much time and effort does this person put into drawing their pain for you on a pain diagram can actually speak to the perceived severity on their end, but also to some prognostic considerations and how they may respond to treatment. I think this is an area of research that's sort of just starting, but I think it'll be really interesting as it goes forward.
That speaks volumes. It's something that we've seen in our practice for decades, and now the research is starting to catch up. It's not just malingering, right? It's not just a someone with a hysterical disposition. It's really meaningful.
Yeah, and depending on the clinical environment you work in, I think I've never seen recent data on this because it would be virtually impossible to figure out, but what's the percentage of malingering? I feel like you have to give people benefit of the doubt. In my particular practice, people are paying out of their own pocket or using their extended health benefits. They're not going to do that if they're faking it. I feel like that mind shift has already happened, and I don't think most people approach patients like they're all malingering. But I think it's kind of interesting that it still kind of shows up sometimes in clinical thought processes. The next one we have is one of the ones that we've spent some time talking about in our biopsychosocial e-seminar that we put together last year. And it's sort of an uncomfortable topic for some chiropractors because I think some people think it's automatically out of our scope of practice or it's not something we should be dealing with. And that is screening for depression and anxiety. So walk us through how you approach that, Dee.
So two things I'll say right off the bat. One, screening for it is not outside our scope of practice. Diagnosing and treating it is. The other thing that's that's very well established here is that clinicians don't, in general, um, the research tells us that clinicians who aren't psychologists or some kind of mental health or behavioral health provider are pretty poor at discovering this. So having a formal kind of screening process for this when you get a sense or an intuition that this is a problem is very, very, very important. And it's something that we screen for even in our practice when we do our pain assessments with our physicians, because even we can miss it sometimes. So it's best just to test for it. So the importance of it, in addition to that person just having another health outcome that is making their overall life difficult, always remember a person's experience is biopsychosocial, and you can't separate the bio, the psycho, and the social. They're all integrated and interwoven and inseparable. The best description of this that I've heard is it's kind of like baking a cake. So if the bio is flour and the psychosocial or sorry, the psychological is eggs and butter, and then the social might be some kind of riser like baking soda or baking powder, you might put all those ingredients, you might make a dough or some kind of pre-cake mixture, you put it into the oven, and that's the environment, and then you come out with something new. Um, so when you take all of those different things, you weave them together, you put them in an environment, and you end up with pain, you end up with an experience. There's no line of eggs and butter, which is psychological. There's no line or layer of flour, which is the bio. You get what I mean? They're all interwoven together and inseparable. So, but one thing that we do know is that when people have beyond a certain intensity or a certain amount of depression and or anxiety, it starts to impact the prognosis that that person might have in the future. So it behooves us to either ask questions about it, very pointed questions about it, after we feel comfortable with the therapeutic alliance, or use a questionnaire, a very short questionnaire that you can use in your office. So there are four really good questions that I like to ask. The first is, do you feel sad? And if so, do you feel sad all or most of the time? Well, a person might say, what does sad mean? Well, what does it mean to you? Right? So if the person feels sad all or most of the time, then they might have some element of depression there. We don't know the intensity of it. The second one is, do you have little interest in doing things that previously brought you joy? And they might say, what does that even mean? They might not even know what it means for things to bring them joy. But if they used to go for a walk with a loved one, or if they used to play soccer or they used to play tennis and they're no longer doing those things because they don't feel motivated to do it, well, those are two really large indicators of depression. So we call that being sad, which is synonymous or a feature of being depressed, but also anhedonia, which is a lack of pleasure in doing things. And the other two relate to anxiety. So are you worried all or most of the time? And the second question is, do you find it hard to control that worry? So if I think of our Italian or Greek yayas or our Italian nonas, oh my God, you're driving in the rain, and I have to watch the weather network the whole time to make sure that the rain isn't coming down too hard and make sure there aren't any accidents on the news, and I'm listening to it. So it's just this worry all the time that's difficult to control, that affects your behavior. If you find that a person is like that, then they might have some anxiety. There are some really good, easy questionnaires to use in clinical practice. One is called the PHQ-2. That's two questions about depression, which are the exact same two questions that I gave you, but it actually has an ordinal scale to give you a score. And then the other one is the GAD-2, GAD-2, which is the exact same two questions I just gave you, but they have an ordinal scale to score it. And if it's beyond a certain measure, you can then say, okay, I'm going to use a more sensitive and specific scale, or you can have a discussion, which might trigger a discussion about what that person's going through with their mood. And it might actually trigger you to make a referral to a behavioral health provider. So you got to think about the holistic aspect of what that person is going through. Depression, anxiety is one of those things.
And I think it boils down to for clinicians to have a plan of how they're going to assess it, and then also have a plan on the backside of that if there's some indication that this is a real problem. I mean, to me, the scope of practice issue comes into play when there's such a severe overlay of those two conditions that it goes that you need some other help. And I think regardless of where you practice, you have to have a network of people that are able to help you with this sort of thing. And I think in the mental health space, one of the best developments in the last few years is the kind of onlineification of therapy. I mean, it's sort of taken barriers of access barriers away for a lot of people who live in more remote areas. So I think that's an important thing to do, and we've discussed that a little bit more in our biopsychosocial course. We'll talk about in a few minutes, but moving on to the next one, asking them about sleep, stress management, and coping strategies. And what I find interesting in an overarching sense about all of this is how it's kind of like the cake metaphor you just mentioned. All of this kind of goes together. And I think inherently, chiropractors have always been good at, or at least claim to be good at, looking at people in a holistic manner. And what I like about this topic and our current evolution and understanding in the literature and how it's all putting the pieces together is that it's supporting an exact model like that. Like it's almost being teed up for us as a profession to do this properly. So, what do we think about sleep, stress, and coping? This could be a whole course in and of itself. Do it for me in 4 minutes.
Absolutely. So the way I think about these variables, and actually all these variables, is that when we're dealing, pain management is no different than managing any other health outcome, right? So take someone with type 2 diabetes. They might take medication to stabilize blood sugar or to help them lose weight. They might need a sleep intervention because we know that destabilizing sleep will destabilize blood sugar. They might need nutritional interventions. They might need stress management because of how that affects glucocorticoid production. And they might need coping strategies to help them deal with a lot of these different variables. Pain management is no different. We're asking people about sleep because we know that a lack of sleep increases systemic inflammation, and we know that it impacts one's ability to cope with daily life. But we also know that when people are sleep deprived, it increases pain intensity and their tolerance to pain. So sleep is a foundational aspect of our health, and it's also a foundational aspect about pain management with an inverse relation, bidirectional relationship. So people who don't sleep very well are have a greater chance of having some kind of sleep disruption. Have some kind of pain condition, while at the same time, people with pain conditions have a greater risk of sleep problems. So
Mhm.
always ask about that. So simple ways to ask about that is, do you have difficulty falling or staying asleep? And if so, why? Do you snore? Is it so loud that people can hear you through a closed door? Do you wake up in the middle of the night gasping for air? Does your partner tell you, if who anybody sleeps beside you, do they tell you whether or not you stop breathing in the middle of the night? So we want to understand, is this a sleep disorder like obstructive sleep apnea, restless legs, or is it run-of-the-mill insomnia, for which things like CBT for insomnia would be first line, right? So as diagnosticians, we need to ask about this. Stress management is huge. Again, it can impact every health outcome. And we think stress is a disease in and of itself. So stress management is very important. So asking people who are in pain, does stress aggravate your pain? Do you have a lot of stress? What's going on in life? How do you cope with stress? Just like we would for every health outcome. And then coping strategies are really about, how do we create the infrastructure for a person to return to their identity or their personhood. So many of the hobbies that we have, many of the things that we do, not only help us with our health and wellness, but they help us manage stress because it removes us from things that light that flint or light that flame. So how do we get people doing the things that bring their life meaning? But it could also mean things like breathing strategies. It could also mean things like movement and mindful movement and things like that. So coping strategy is a very broad term, but it's really about working with that person with what coping strategies mean for them. So these are general health concerns that we as diagnosticians and clinicians who treat people with health concerns need to think about, and they impact pain largely.
And no matter how would they study sleep, the impact of sleep is critical for everything. It's for, cognitive functioning, for emotional health and mental health, and it's all kind of tied together. And it even links in with exercise and fitness a little bit. And I just think it's interesting how we're starting to appreciate how it's all these bits and pieces of someone's life, how it boils down to the back pain that shows up in our office that we used to think was just back pain, but it actually is a lot more than that. And I think it gives us more, you and I mentioned touch points all the time. It's a different thing to do with a patient that might be beneficial for them. And I think it's worth mentioning here. Sometimes the overwhelm for clinicians is like, well, how am I supposed to screen them for depression, talk about sleep stress management? I have like 40 minutes to do an initial appointment. But I think it's worth pausing here for a moment to say that, again, we have the luxury of time and multiple appointments, generally speaking. So you don't have to do all this on day one. I always say your job on day one is to rule out red flags, make sure they're not dying, and kind of go from there and then decide what kind of person you have and do your assessment accordingly. But a lot of these things we talk about, and you could put nutrition in this category too. It didn't make our list today, but we can talk about that some other time is just make sure that they're putting the individual's putting all the pieces together to set themselves up for success the best way they can. And you can be a facilitator of that in whatever way you feel comfortable in terms of your training or clinical experience. But stress management and coping is certainly a broad area. But the sleep is now being tied to literally everything, and that brings up other things about, using wearables to track your sleep, which can have a nocivic effect as well if you're so worried about your sleep stats from your Whoop or from your Fitbit. But those are, maybe topics for another day. But sleep, generally very important, correlates with a multitude of musculoskeletal conditions. And we sort of artificially lump sleep and stress management in there, but I think they go together pretty well.
One impacts the other, right? Like people ruminate about their day and it stops them from sleeping, and then people become more stressed because they're not sleeping. So we can think about one impacts the other in a bidirectional manner, right?
For sure. It's a doom loop, right? If
Yeah.
one or both aren't going very well together. Number six on our list was leveraging history taking to develop a therapeutic alliance. And for those of you that have taken my courses in person over the years, I talk a lot about, history taking and getting to know your patient and how maybe we should upskill ourselves on that a little bit. But I think it's also allotting proper time to it. So what are the benefits of this aspect of the clinical encounter, D?
Well, we know that developing a very rich therapeutic alliance, which I think chiropractors do really well. So we're kind of preaching to the converted here.
That's
Uh,
fair. Yeah.
yeah, I mean, if you watch a physician take a history, an orthopedic surgeon take a history, it's very different, it's incredibly different. So developing a good therapeutic alliance is really tied to outcomes. Like we will have more favorable outcomes, we will get fewer complaints, people will be more happy with treatment if the relationship that they develop with their healthcare provider is better. So it's really about not necessarily understanding pain and where the pain is coming from, but it's also understanding the person themselves. So asking questions about all of these things that we've touched on is one way to do that. So some questions that I might ask to understand the person, in addition to understanding the context of their life and all that stuff, what they do, what their likes and dislikes are, so what is this pain stopping you from doing? Right? Especially in the context of chronic pain. And acute pain, oh, it's stopping me from doing the laundry. I can't bend forward. That's more than likely to resolve. But in the context of chronic pain, that's a big thing. It's a very big thing because people's lives have been put on hold. So that's the way you got to think about it. And you can even sell that question to a patient in that way. With the people that I've seen, it seems as if their lives have been put on hold. It stops them from doing the things that they would otherwise be doing with their life. So if I snap my fingers and pain was gone, that's another way I phrase it. How would life be different? What would you be doing differently? And from that, you can ask more and more and more questions pertaining to what those activities are. Some people might say everything. Okay, well, give me your top three.
Mhm.
I would be going for a walk every night with my partner because I love that, and I would be playing tennis again, and I would be lifting weights in the gym, or I'd be going to the park with my kids. Was you've now just It's those three things can be like cutting limbs off. Very special things. So what you've done there is you now understand the extent of these people's suffering. You can say, oh my God, that must be very traumatic that you can't do these things. It would be very meaningful to you to be able to do those things again in some way. Yes, we've now bonded. But the other thing that you've done is you understand what a favorable outcome looks like, right? And now you've gotten into the psyche of the person is to say, that's what a successful treatment program looks like, right? It's getting the person back to life. And then you can develop goals from there, right? So you can put person on a walking program. You can say, okay, if we start lifting, can we do it this way? And so on and so forth. So it kind of steers your treatment plan, but it also makes you understand the person and the extent of their suffering more.
And it's a different way, isn't it, than asking someone overtly, what are your goals? Because if you ask them that, most people don't know what to say. But if you ask it in that way, like if I were to make this better for you, what would that mean for you and what would you get back to?
Earth.
Yeah, like the three or four things they're going to list for you can be outcome measures for your treatment, and they've just handed them to you. And those are patient-centered. They've already identified them as important to you. So you're kind of doing two lifting on both fronts with one set of questions. So I think, like you said, this is something that chiropractors tend to do very well. However, what I'll also add to that is I think sometimes we race through the history to get to the treatment part. And I'm not saying treatment is not important, but I think one of the things this literature and this new knowledge should impart to our colleagues is that the rest of the clinical encounter is as important as the treatment part. So don't sacrifice one at the expense of the other. And I think what I always did in clinical practice, if I was referred a patient that we knew was a more complex case, I would give them more time. Like my initial appointment was an hour. Sometimes I would book an hour and a half or an hour and a quarter. I wouldn't necessarily charge them for it and I wouldn't necessarily use it, but I would just make it available in case I needed it. And I think some extra time spent in the initial appointment to establish that therapeutic alliance is an investment that'll keep paying off throughout the course of care for a patient. And I also think for many chronic pain patients, we'll be the first healthcare provider that has listened to their whole story, given it some meaning for them, acknowledged their suffering and what it means to them from a number of different perspectives. So I think that investment pays lots of dividends down the road from patient retention all the way to referrals. So I think it's really important that we leverage that in clinical practice.
Absolutely.
The last one we put on our list here, and then we can get to some questions if you guys have questions, is to promote physical activity as part of management for chronic pain patients.
So first of all, this is guideline concordant, and it's guideline concordant for pretty much every healthcare condition that someone can suffer from. The one thing that I'll say is, first of all, getting patients to be more physically active is tough, right? So what we really have to do is tie that to what their goals are. And understanding what their goals are is understanding of what their suffering is. And understanding what their suffering is means building therapeutic alliance. So it kind of comes all the way back. There's no gold standard for exercise for chronic pain. People are different. There's no one exercise that's better than another. So why not figure out what that person wants to do and help them figure out a way to actively do that, right? And that's how you sell it, right? And you meet them where they are, where their capabilities are, and what they're willing to do, and titrate that over time. The one thing that we get stuck on as healthcare providers in general is this number of 150 minutes of moderate exercise, moderate intensity exercise per week. So we think you got to be doing 30 minutes 5 days a week. And some people who just walk from their car to the office and from their car home, and that's all they do, will find that overwhelming. So while the lowest relative risk of healthcare, like negative healthcare outcomes and mortality, is at that 150-minute figure, that's where it is at its lowest. But the biggest bang for your buck comes from going from doing nothing to doing something.
Mhm.
And one thing that we know about pain is that the analgesic benefit of exercise happens at much lower quantities than the overall health outcomes. So just think about what little change can I make? So I had a patient who gets no physical activity. She has a chronic radicular pain. And she takes her kid to baseball all the time. She doesn't have time to, and she drives 2 hours to and from work. So it was just like when you're watching your kid play baseball, can you park a little bit further away? Can you get up between meetings and just do a walk around the office and come back? Can you, during a game between innings, just go for a walk to the end of the diamond and back? So that way you're building it into your daily life without it being structured. So little changes have massive effects on overall health, and little changes accumulated over time have a massive effect on function and pain.
Yeah, and by the nature of their clinical scenario, I think a lot of chronic pain patients are kind of starting from zero, right? To your point, you don't have to get them from zero to hero right up to guideline concordant exercise levels. It's about getting them to move a bit more tomorrow than they move today. And that can help with their pain levels in general, and it can combat kinesiophobia. It can raise their self-confidence in their ability to have some agency over their pain condition. And the way I always think about exercise is there's literally no downside, unless, notwithstanding an injury or something you have to manage in that sense, to avoid. But it's about finding the best mode of exercise for an individual patient is one that they're going to enjoy and actually do. And I think we get lost in those weeds sometimes too when you look at systematic reviews about what exercise is better for back pain. It doesn't matter for the most part. Not surprisingly, the clinical trial results are pretty wishy-washy in terms of what's better, because I think it's if someone sticks with a form of exercise, it's important. And I think for our profession to gain additional cultural authority and respect in a broader healthcare sense, it's very important for us to continue to integrate physical activity and rehab into everything we do, chronic pain and beyond.
Absolutely. As you said, there's no downside. It's good for your overall health, and people will benefit with enough effort and time. And the way I think about it is it's about touch points over time. It's about volume over time. So people don't have to do a certain dose. With some people, I just get them who live in apartments. I just say, every couple of hours, just walk the hallway and back. And it's just about doing that and accumulating over days, weeks, and months to change that behavior. And as soon as you light that fire, it'll grow.
Yeah, you can microdose exercise, right? And it adds up over time. And I think we've also learned that cumulative exercise is as beneficial as purposeful, like half an hour at a time.
Yeah,
For most people starting at a lower baseline, you can get there with smaller doses that are easier to implement.
absolutely.
So we won't belabor these. We've talked about most of them in terms of our clinical responsibilities, but in the interest of getting to a few questions as we're approaching 1 o'clock. We've mentioned a couple of times the course that we put together. This course was presented by myself and Dr. Assimakopoulos and Dr. Kent Stuber and Dr. Peter Stillwell. And our goal here was to operationalize what it means to be a biopsychosocial chiropractor, because we're always told to practice in this way, but those clinical guidelines and papers and things that recommend biopsychosocial care kind of stop there and don't tell us what it means. So in that course, we integrated a lot of the concepts we talked about today in terms of screening for depression, developing a therapeutic alliance, tips and examples of receiving a patient history, how to deliver a diagnosis in patient-centered language, deploying patient education strategies, and so on. And with my bias fully out front, and Demetri's probably as well, I think this is kind of core curriculum if you're a chiropractor dealing with any sort of patient. And a lot of chiropractors don't necessarily think this topic is sexy, but it's really that course, in my opinion, is one of the most helpful ones that I've ever created, and we think it's pretty important. It's a 4-hour video-based e-seminar, and again, I'll send you a coupon code for 30% off that one if you're interested in a deeper dive there. So I think hopefully in the 7 tips we put together today, we're helping to put some pieces together for you as clinical practitioners dealing with chronic pain patients. I think the literature just continues to add positive news for chiropractors and supporting a traditional and a contemporary chiropractic approach to healthcare, including touch and patient-centered care, developing a therapeutic alliance, assessing all different parts of someone's health and seeing what matters to an individual patient, recognizing that not everybody needs everything done to them all the time about all the things we talked about today. It's about picking what matters to the person in front of you and putting the pieces together. So with that, this will be the last webinar before fall. I have 7 or 8 topics in mind for the next season. We'll kind of go back to the regular format, second or third Thursday of the month. I'll get a few of the newer ones posted soon. And now that we've reached 1 o'clock, we actually timed that pretty well. Demetri and I are happy to take some questions if we want to jump on cameras, or if you have anything you'd like to ask us in the chat, we're happy to stick around for a few minutes. While we wait for people to do that, Dee, I have one question for you. Back to my phenotyping question.
Go for
What, which phenotype, if there is one, this might be an unfair question. I didn't warn you I was going to ask you this, but in average chiropractic practice, which phenotype do you think we miss the most? Like, which one do you think we should be on the lookout for that's common that we're not necessarily identifying and managing properly? Is there one on your list that you think fits that?
It does depend on the practice itself, but I'd say nociplastic. I think nociplastic is very common. And I think intuitively we might know it's nociplastic, but a lot of people don't have the language to describe it. Um, but yeah, my answer would more than likely be nociplastic.
Okay. And what's what do you think the most follow-up question? This is for my interest too. What do you think the best, if you had 1 or 2 techniques or treatment things to think about to add to patients who you think have nociplastic pain, what would they be over and above manual therapy?
Oh boy.
Yeah,
Uh,
you're welcome.
two most two most important, probably sleep and changing physical activity. So sometimes people with nociplastic pain, they go through this boom bust cycle. So they almost do too much and then they tank for a number of days and because their pain gets really bad and then they might get better and then they kind of do this thing where they boom and bust. So being able to identify what a tolerable but overall increasing dose of physical activity that person can tolerate is very important. So that might be everything from incidental activities they do with their day. So on a good day, are they going to the bank and doing their laundry and doing all their shopping and taking their kids to school and blah, 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 and then they're in bed for 3 days? Boom, bust.
Yeah.
They start to separate these things over the course of a week and say, okay, I can do this amount of things, this amount of time of things. I'm not dictated by my pain response. I'm dictated by how much time I can spend doing these things. And you integrate rest periods in order to minimize that boom and bust. Now, sometimes people need a little bit more, sometimes people need a little bit less. But that's why I say start to identify what that pattern is and make it time contingent as opposed to like volume contingent or pain contingent.
Okay. Interesting. Thank you. Do we have any questions? Everyone's shy. Don't be shy.
I don't bite much.
No. All right. Well, do you have anything else you want to mention before we?
Thank you for the lovely compliment, Keith. Dr. Huang, if I'm pronouncing that correctly, you mentioned here for secondary gain, such as WSIB. Do you mind giving me a bit more context, please? And feel free to unmute yourself. You don't have to turn the camera on. Sorry.
Here we go. It's coming.
Thank you, Anita. So you work with the surgeons, you do assessments.
Are you asking how do we identify people who are just out for secondary gain? We sort of mentioned it's not that common. Is that what you're asking? Okay.
So
How do you pick out a faker, D?
Actually,
It's not a faker. I shouldn't say that. It's not faking. It's a different concept. I'll let you answer that.
it's really interesting because when I was in Pittsburgh lecturing, I was talking to people in the VA about this. Um, and it's really hard. I think I reviewed something on the service. I reviewed an article on, it was a systematic review and meta-analysis on identifying people who have secondary gain or are malingering. And there's actually no good way to do that rather than catching them other than catching them red-handed. So there's no good way to identify malingering because all of our non-organic signs are really just finding people who are really sensitive to pain or maybe have nociplastic pain or have a lot of distress as it relates to pain. So things like neuropsychological testing, clinical testing, like all that stuff kind of sucks. Questionnaires, they're all not very good. So the only way you can identify people who are in it for secondary gain is that you ask them and somehow they tell you. There's no better way to do it, unfortunately, that we have right now.
Interesting. So we've sort of moved away from, the non-organic pain signs and trying to sort of trick a patient who's trying to trick us, right?
Yeah, there's no good way to do it. The body pain diagram, again, it'll tell you the stress, it'll tell you, is there a nociplastic? It makes you ask more questions. So yeah, if there's one thing I would do if you're not using it, I would use the body pain diagram for sure.
Yeah. Okay. Any other questions? That means we've answered them all, D. We should be happy.
Okay.
We solved it.
Solve chronic pain.
All right. Well, with that, thanks everyone for attending live. For those of you that joined us, and for those of you watching, thank you for watching. We hope to see you at future webinars. And like I said, I'll have a newer schedule up in the next month or so for the fall events. And I think, Dee, we should do this again sometime. This was fun.
It was really fun. I want to thank you, Sean, for allowing me to be on your platforms. I mean, you're one of my dearest friends, and it's always a pleasure working with you. And thank you, everyone, for your time. I appreciate you.
All right. Thank you, pal. All right. We'll talk soon, everyone. Take care. Bye for now.